Hello students, I am Dr. K. Himaja, Assistant Professor in Department of Prosthodontics and Crown and Bridge from Vinayaka Mission Shankaracharya's Dental College, Salem. Today we are going to learn about mouth preparations in removable partial dentures. Preparation of mouth is fundamental to a successful RPD service. Mouth preparation follows the preliminary diagnosis and development of a tentative treatment plan. According to Renner Boucher, mouth preparations are defined as those procedures that are accomplished to prepare the mouth for the reception of the prosthesis. Mouth preparation are classified into prosthodontic procedures and non-prosthodontic procedures. In prosthodontic procedures, it includes procedures related to occlusion and restorative dentistry. In non-prosthodontic procedures include oral surgery, orthodontics, periodontics and endodontics. When to perform mouth preparations? Naturally, mouth preparations must be accomplished before the impression procedures that will produce the master cast on which the RPD will be fabricated. If at all possible, at least 6 weeks and preferably 3 to 6 months should be provided between surgical and restorative dentistry procedures. This depends on the extent of the surgery. Objectives of mouth preparation. It helps to establish state of health in supporting tissues, eliminating interferences or obstructions, establishing acceptable occlusal plane, alteration of natural tooth form for the requirements of form and function of the prosthesis. Planning mouth preparations. When an RPD is identified as the preferred choice of treatment, an orderly sequential plan of action should include a thorough examination of the patient, including familial, general health, dental histories, present dental conditions like tooth vitality, mobility, and periodontal evaluation is needed. A complete row and genographic survey, accurate diagnostic cast, and mounting them on a suitable dental articulator in centric relation. Surveying of the diagnostic cast, diagnosis and evaluation of the data gathered from the examinations. Following this helps to meet patient-specific needs to design RPD. Recording mouth preparations include recording on the diagnostic cast, charting on a prepared form, coding selective grinding procedures, symbols used in charting mouth preparations. Recording on the diagnostic cast, usually executed using a red pencil to identify the mouth preparations to be accomplished. Teeth to be extracted are marked with X. Some dentists prefer to remove the dental stone teeth from the diagnostic cast and identify that extraction site with an X. Areas of bony and soft tissue recountering are outlined with closely spaced parallel lines are shaded with a red pencil. Tooth structures to be altered are outlined or shaded. This include those areas necessary to prepare rest seats, guiding planes, modification of survey lines, occlusal refinements and removal of the interferences. Charting on a prepared form. They indicate a complete listing of all procedures needed to prepare the patient's mouth to receive RPD. They indicate the sequence in which the procedures can be executed most expeditiously. Symbols used in charting mouth preparations. Appropriate symbols should be used to expedite the charting of mouth preparations when they are recorded on the chart. The goal is accurate communication in the charting procedures. For example, the term survey line means SL. In the same way, guiding plane will be represented as GP. Coding selective grinding procedures. The objective is to remove a specific amount of tooth structure from a specific areas. Coding ranges from 1 to 5. 1 means a very little amount of tooth structure need to be removed, whereas 5 means extreme amount of tooth structure need to be removed from restored tooth surface. Non-prosthodontic preparations. Relief of pain and infection. Dental conditions causing pain or discomfort should be treated to eliminate pain. Large carious lesions which is asymptomatic should be restored with an intermediate restorations to prevent possibility of any acute pain during treatment. Calculus accumulation should be debrided. Plaque should be controlled. Preventive dental hygiene program should be started and vigorously monitored. Non-strategic teeth that would present complications or those that might be detrimental to the design of the prosthesis need to be extracted. Impacted teeth that become source of spread of infection to to the adjacent healthy teeth need to be removed. Asymptomatic impacted teeth covered with bone in elderly individuals with no evidence of pathology should be left to preserve the arch morphology. This should be documented in patient records. Panoramic radiographs are recommended to survey the jaws for unusual pathologies. Since odontogenic tumors should be removed because their presence may compromise the design of the removable partial dentures. Exostosis, tori, hyperplastic tissues which will compromise the design of RPDs need to be removed. Muzzle attachment and frena. Appropriate ridge extension procedures can reposition attachments which will enhance the comfort and function of the prosthesis. Maxillary labial and mandibular lingual frena are most common source of interference and can be modified with surgery. Bony spicules and knife edge ridges. Bony spicules need to be removed and knife edge ridges should be rounded without compromising the height of the alveolar bone. However, correction of knife edge alveolar ridges causes insufficient ridge support, then vestibular deepening procedures or insertion of bone graft material should be carried out. Polyps, papillomas and traumatic hemangiomas, all abnormal soft tissue lesions should be excised and submitted for pathologic examination before fabrication of removable partial dentures. Dentofacial deformity. Patients with dentofacial deformity often have multiple missing teeth as the part of their problem. Correction of the jaw deformity can simplify the dental rehabilitation. Augmentation of alveolar bone. Deficient alveolar bone can be corrected through ridge augmentation procedures. Conditioning of abused and irritated tissue. Tissue conditioning is required if denture-bearing mucosa is inflamed or irritated. Anatomical structures like rugae, incisive papilla and retromolar pad are distorted. Burning sensation in tongue, ridge area, cheeks and lips. These conditions are usually associated with ill-fitting or poorly occluding removable partial dentures. Proper home care and using a prescribed therapeutic multivitamin tablets helps in treating irritated tissues. Tissue conditioning materials have a soothing effect on irritated mucosa. Periodontal preparations. The periodontal procedures follows simultaneously along with oral surgical procedures and is completed before restorative procedures. The success of prosthesis depends on the health and integrity of periodontal tissues of the remaining teeth. Endodontic treatment. Tooth with pulpal involvement and root end morphology requires endodontic therapy. Restorative therapy like crowns, inlays, onlays should be programmed to contribute restoration of best possible occlusal plane. Endodontic treatment will reduce the need for prosthetic teeth as much as possible. Position the teeth to allow the most natural prosthetic replacement of teeth. Create vertical sufficient height to allow room for placement of artificial teeth. Coming to prosthodontic preparations, correction of occlusal plane discrepancies. Early in the diagnosis and treatment planning, the dentist must evaluate the patient's occlusion. Basically, the dentist must determine the type of occlusion the patient has, whether there is a need to change or modify patient's existing occlusion, whether the intercuspal position is in harmony with the patient's centric jaw relation and the state of plane of occlusion and occlusal curve. The occlusion plane in most partially edentulous mouths will be uneven. The severity of this unevenness will determine the treatment needed to correct the condition. The teeth that have been adopposed for a prolonged period of time tend to supra-erupt. In maxillary posterior regions, supra-eruption may also be accompanied by a downward migration of the tuberosities. So, surgical reduction of the tuberosities may be needed to provide adequate space for a removable partial denture. Enameloplasty, the intentional alteration of the occlusal surfaces of teeth to change their form. The need for these alterations depend upon design of RPD framework and the shape of tooth in relation to the chosen path of placement and removal of the prosthesis. Infra-erupted teeth. They create defects in the plane of occlusion that can be successfully managed by one or three methods. by orthodontic repositioning, placement of cast restoration on the tooth to increase the clinical crown, use of an occlusal onlay as a part of the RPD or as an onlay rest to restore the clinical crown to the plane of occlusal. Correction of malalignment teeth. It can be done by orthodontic therapy or by enameloplasty or by giving fixed restorations. In moderate malalignment of teeth, it can be corrected using properly designed fixed restorations. Provision of support for periodontically weakened tooth. Splinting of posterior teeth provides additional resistance to anterior posterior forces but not mediolateral forces. This is due to linear arrangement of posterior teeth. In order to improve resistance to mediolateral forces, splinting must include one or more anterior teeth. This places the restoration in an additional plane and provides a L-beam effect. A tooth that has lost more than 50% of its bone support is a poor candidate for fixed splinting. In such situation, fixed splinting weakens the stronger tooth rather than strengthening the weaker tooth. So, splinting may be provided by removable partial dentures. The swing lock removable partial dentures is particularly useful in these situations. Re-establishment of arch continuity. A lone standing tooth adjacent to an edentulous area is termed as pier abutment. Experience indicates that placing a clasp on such tooth leads to periodontal destruction and abutment loss. Consequently, pier abutments may receive rest but generally are not clasped. When a long-standing abutment is present, the practitioner should determine whether the patient would benefit from placement of fixed partial denture. Preparing guiding planes. Guiding planes are naturally occurring or prepared parallel areas on vertical tooth surfaces that are contacted by certain rigid parts of the RPD framework during the placement and removal of the prosthesis. Length. Guiding planes should be longer occlusogingivally for tooth supported prosthesis than for distal extension prosthesis. Proximal guiding planes for tooth supported prosthesis should be approximately 1/2 to 2/3 the length of occlusogingival dimension of the coronal enamel. The guiding plane should extend from the marginal ridge cervically. In distal extension prosthesis should be 1/3 to 1/2 of the occlusocervical dimension of the coronal enamel. Width. From an occlusal view, guiding planes on proximal tooth surfaces may be slightly curved buccolingually to more or less follow the natural tooth contour. Buccolingually, guiding planes on proximal tooth surfaces should be about 2/3 as wide as the distance between the buccal and lingual cusp tips. Advantages. Guiding planes helps in easy insertion and removal of the prosthesis, thus less vulnerable to breakage. Minimize the wedging stress on the abutment, contribute to horizontal stability of prosthesis, contribute to overall retention of prosthesis, and it will reduce undercuts between the proximal tooth surface and the minor character, thus keeps the prosthesis hygienic. It lowers the height of the contour of proximal surface of tooth and permits some rigid portion of clasp closer to the gingival margin of tooth, thus less visibility of the clasp is seen. And it also aids in stabilizing individual teeth. Guiding planes can be prepared on abutment as follows. Abutment adjacent to tooth supported segments. Firstly, diagnostic cast mounted on surveying table at the desired tilt should be placed on tray in front of the operator. Handpiece with cylindrical diamond point is positioned over abutment tooth on cast to visualize the correct angulation. Tooth is prepared using gentle light sweeping stroke from buccal line angle to the lingual line angle. Flat surface created should be 2 to 4 mm occlusogingival height. Reduction should follow curvature of proximal surface. All prepared surfaces need to be polished using carborundum discs. Abutments adjacent to distal extension bases. Occlusogingival height of preparation is 1.5 to 2 mm. This permits slight rotation around the distal occlusal rest, which avoids torquing forces on distal abutment tooth. Lingual surfaces of abutments. This is done to provide maximum resistance to lateral stresses. Occlusogingival height of preparation is 2 to 4 mm and it is located in the middle third of the crown. Contour of gingival third should not be changed because it can cause damage to marginal gingiva due to improper foot deflection. Anterior abutment teeth provides parallelism ensuring stabilization, minimizes wedging action, reduces undesirable space between denture and abutment teeth and enhances aesthetics. Increases retention through frictional resistance. Restores normal width of edentulous space. Modification of height of contour is done to provide ideal placement of clasp palms and remove interferences for placement of major connectors. Maxillary posterior teeth tend to tip buccally, making placement of retentive terminal unaesthetic. Mandibular posteriors tip lingually, making it difficult to place reciprocal arm and lingual major connectors. In both these cases, height of contour will be near the occlusal surfaces. Amount of correction depends upon the thickness of enamel. If dentin is exposed, placement of restoration is considered. Preparation is best done with tapered diamond stones. Coming to selective grinding, tooth alteration by selective grinding are often necessary to achieve acceptable survey lines for appropriate clasp placement. Survey lines can be lowered but not raised by selective grinding. When survey lines are extremely high and the degree of undercut is severe, the teeth are often selectively ground to lower the survey line, thus reducing the degree of undercut so that the retentive arm tip can be placed more gingivally. Preparation of retentive undercut. There are 4 common methods to prepare retentive undercut. There are crowns, cast restorations, dimpling and tilting the cast. Preparation of retentive undercut, dimpling. Enameloplasty modify retentive undercuts is called dimpling, performed to increase a less than adequate retentive undercut. It should be avoided if there is another undercut exists. Dimpling should be 0.010 inch deep, measured from a line parallel to the path of insertion. Depression should be 4 mm in mesiodistally, 2 mm in occlusogingivally. It should be highly polished. Preparing rest seat. According to GPT-9, rest seats are defined as prepared rests in a tooth or restorations created to receive the occlusal, incisal, cingulum or lingual rests. The preparation of the rest seat should follow all selective grinding procedures. Because if the rest seats were prepared first the selective grinding to create guiding planes, this would alter the character of the rest preparations. Rest seat preparations for posterior teeth. The outline form of occlusal rest seat is basically triangular in shape, with the base of the triangle at the marginal ridge and the apex pointing towards the center of the tooth. The floor of the occlusal rest seat must be inclined towards the center of the tooth and must be spoon shaped. The occlusal rest seat should be at least 0.5 mm thick at its thinnest point depending upon the metal used for rest preparation and 1 to 1.5 mm when crosses the marginal ridge. Width of the occlusal rest sheet should vary from 1/3 to 1/2 of mesiodistal diameter of the tooth, that is approximately 3 mm. Rest seat preparation using round burr may lead to mechanical undercuts, as you can see here. So in order to eliminate this mechanical undercuts, a tapered cylinder burr can be used. Occlusal rest seat preparation in new cast crown restorations. Occlusal rest seat in cast gold restoration should always be placed while making the wax pattern. Sufficient occlusal clearance should be provided to permit proper dimensions of the rest seat. A depression is added to the preparation to accommodate rest seat. Rest seat in wax pattern prepared and then it is cast. Rest seat preparations in existing crown restorations. The greatest problem arises in developing adequate rest seats in existing crown restorations. Often there is insufficient gold to permit adequate preparations. This may result in perforation of the casting and exposure of the underlying tooth. Occlusal rest seat in amalgam restorations is less desirable as amalgam alloy tend to flow under constant pressure. Rest seat preparation for embrasure clasp. The preparation extends over the occlusal embrasure of two approximating posterior teeth from the mesial fossa of one tooth to the distal fossa of the other tooth. Each marginal ridge is reduced to the same amount. The contact point should not be broken because the wedging action and the foot impaction between the teeth may take place. It should be 1.5 to 2 mm wide and 1 to 1.5 mm deep. Rest seat preparation for anterior teeth. Lingual rest seat preparation in enamel. It is also known as cingulum rest seat. An occlusal rest seat on molar is preferred over lingual or an incisal rest seat as forces are better directed along long axis of tooth with the former. Canine is preferred over incisor. When canine is absent, multiple rest seats on incisor are required. A lingual rest seat is preferred over incisal rest seat. Lingual rest seats are aesthetic and less subject to breaking and distortion. Outline form of the cingulum rest seat is half moon shape. It forms a smooth curve from one marginal ridge crossing the center of the tooth incisally to the cingulum. The deepest point of the rest seat is over the cingulum. The rest seat itself is a V-shaped notch with its line angles well rounded. For the preparation, 1/4 inch diamond disc is used. Incisal rest seat preparation. Incisal rests are the least desirable rests for anterior teeth and are the last resort to stabilize the removable prosthesis only on sound abutment teeth. 1.5 to 2 mm deep and 2 to 3 mm away from the incisal edge. 2 to 3 mm away from the incisal edge. If the incisal rest is used in conjugation with circumferential clasp, the rest seat should be placed at the distal incisal edge. And if it is used in conjugation with bar clasp engaging distobuccal undercut, the rest seat should be placed at the mesial incisal edge to reciprocate the bar clasp. Conclusion: the preparation of mouth is a crucial step for successful removable partial denture. A more critical evaluation of the comparative worth of a prospective abutment and the next adjacent tooth is made to prevent appliance failure due to abutment loss. The sequence of the events of mouth preparation is essential for the success of removable partial denture treatment. These are my references. Thank you for watching my class.